Advanced Pharmacology Study Notes Women's Health. The FDA categorizes 5 categories A, B, C, D, X based on clinical data, animal and human, and estimated risk-benefit ratio if a drug is given. This is pregnancy categories. Category A, controlled studies in women fail to demonstrate a risk to the fetus in the first trimester, and there is no evidence of a risk in later trimester, and the possibility of fetal harm appears remote. Category B, either animal reproduction studies have not demonstrated a fetal risk, but there are no controlled studies in pregnant women, or animal reproduction studies have shown an adverse effect other than a decrease in fertility that was not confirmed in controlled studies in women in the first trimester, and there is no evidence of a risk in later trimesters. Category C, either studies in animals have revealed adverse effects on the fetus, teratogenicity, or embryoncidal or other, and there are no controlled studies in women, or studies in women and animals are not available. Drugs shown should be given only if the potential benefit justifies the potential risk to the fetus. Pregnancy category C is given to medications that have not been studied in pregnant humans, but that do appear to cause harm to the fetus in animal studies. Category D, there is positive evidence of human fetal risk, but the benefits from use in pregnant women may be acceptable despite the risk, such as if the drug is needed in a life-threatening situation or for a serious disease for which safer drugs cannot be used or are ineffective. Category X, studies in animals or human beings have demonstrated fetal abnormalities, or there is evidence of fetal risk based on human experience or both, and the risk of the use of the drug in pregnant women clearly outweighs any possible benefit. The drug is contraindicated in women who are or may become pregnant. Note, because of certain limitations as seen in discussion threads, this system is being replaced but is still widely used. The main criticism of the category system is that it oversimplifies what is in fact a very complicated, individualized clinical decision. The risk of untreated illness and or possible benefits of the medication are mentioned briefly as considerations, but are not elaborated on and are often overshadowed by the perception of risk of the medication. Other shortcomings. The current labeling system does not reflect the timing of exposure and the effects of drug exposure at various times of the pregnancy. For example, exposure to lithium during the first trimester carries different risks than exposure to lithium during the third trimester. It is often assumed that medications within the same category carry the same risk. Lithium and valproic acid are both in category D. However, lithium carries a 0.1% risk of a cardiovascular malformation called Epstein's anomaly, whereas valproic acid carries a risk of major malformations of between 7 and 10%. The FDA does not update labeling based on new findings. Paroxetine was changed to category D. However, when new data suggests that there was no increased risk of cardiovascular malformation, the labeling remained the same. Finally, there is no information on the use of medications during lactation. Pregnancy and Lactation Labeling Rule, PLLR. In December 2014, the FDA published PLLR, Narrative Model for Drug Labeling. It requires pregnancy-related information to be provided under 3 sections on the prescription label: pregnancy, lactation, and females and males of reproductive potential. It summarizes risks to the fetus, illness-related clinical considerations, and available safety data. Replace the risk categories with supportive evidence-based decisions. Again, in the PLLR rule, so we've got 8.1 is pregnancy. So pregnancy exposure registry, if applicable. And then so we've got risk summary. So a statement that the drug is contraindicated during pregnancy, if applicable. Risk statement based on human data. Risk statement based on animal data. Risk statement based on pharmacology. And then background, birth defects and miscarriage rates. And then under clinical considerations, if applicable, disease-associated maternal and or embryo-fetal risk, dose adjustments during pregnancy and the postpartum periods, maternal adverse reactions, fetal neonatal adverse reactions, labor and delivery. And then data, if applicable, and then which is the data on which the risk summary and clinical considerations are based. And then the same goes in lactation, and then females and males of reproduction potential. Red flag medications commonly used: teratogenicity. So, and he's got this in red: warfarin, phenytoin, valproic acid, carbamazepine, lithium, ACE inhibitors or ARBs, thalidomide. That's the one that people were taking for nausea and vomiting and gave all their children missing pieces of their extremities. Ethanol, statins, etc. Considerations must be given to not only those who are pregnant, but all women of childbearing years where pregnancy is possible, planned or unplanned. Note, this is not a comprehensive list, but a good representation for exam purposes. So, let's say those again. Red flag medications commonly used that are teratogenicity, so they cause issues in the fetus: warfarin, phenytoin, valproic acid, carbamazepine, lithium, ACE inhibitors or ARBs, thalidomide, ethanol, statins, etc. Combined oral contraception. Also, just so you know, he has a red mark on table 48.3, so make sure you go back and look at that. Combined oral contraception. Choosing a formulation based on fertility goals, patient preference, discussion of risks versus benefits, history to rule out contraindications. The World Health Organization and the Food Drug Administration recommend using the lowest dose pill that is effective. As noted below, efficacy can be impacted by several factors, including other medications. Thus, the lowest dose available is not always the lowest, most effective dose. Risk can include, but not limited to, cancers, cardiovascular events / hypertension, VTE, and drug interactions. Drug interactions. Concomitant use of broad-spectrum antibiotics and combination contraceptives may result in decreased contraceptive efficacy. However, this is Category 1 under the USMEC. In red, he has, if a typical failure rate of 1% to 3% is a concern for the patient, consider additional or alternative forms of birth control. Concomitant use of P40 enzyme inducers such as rifampin, phenytoin, carbamazepine, and phenobarbital may result in decreased contraceptive efficacy. If using a COC, use higher doses, at least 35 micrograms EE, plus high progesterone, shorten hormone-free interval to 4 days or less. Avoid low progesterone, the patch or POP, and then consider additional or alternative forms of birth control. Concomitant use of anti-HIV protease inhibitors can either increase or decrease serum levels of estrogens and progesterones and may need a backup method. Drospirenone can cause hyperkalemia, especially if used with other agents that can increase potassium, such as ACEs, heparin, aldosterone antagonists, etc. And then he has table 49-5 in here, so make sure you look at it. Benefits can include favorable effect on bone, menstrual effects, improved acne, improved PMDD, etc. And then he has managing adverse effects, table 49-4 in red. So make sure you look at that table especially. Estrogen. Excess nausea, vomiting, cervical mucorrhea, hypertension, headache, breast tenderness, edema, melasma, and bloating. Estrogen deficiency. Early or mid-cycle breakthrough bleeding, increased spotting, hypomenorrhea, vasomotor symptoms. Progesterone excess, breast tenderness, headache, fatigue, changes in mood. Deficiency, late breakthrough bleeding, hypermenorrhea, dysmenorrhea. Androgen excess, increased appetite, weight gain, acne, oily skin, hirsutism, decreased libido, increased breast size, breast tenderness, increased LDL, decreased HDL. Amenorrhea, rule out other causes, can increase to more estrogenic formulation or to triphasic formula to decrease amenorrhea. It's not a concern if the patient is happy. Acne, oily skin, or hirsutism, rule out other causes. switch to less androgenic formulation of progesterone, or decrease progestin content. Third generation desogestrel or norgestimate. Fourth generation drospirenone or Dienogest. GI typically resolves in 1 to 3 months. Decreased estrogen component will help with nausea. Decreased progesterone component to help with bloating and constipation. Bleeding or spotting is common in 30 to 50% when first initiated. Often resolves by third or fourth cycle. Other manipulations of estrogen and progesterone depend at the point of cycle bleeding or spotting occurs. First, rule out other causes, including medications such as medications that increase metabolism. If spotting or bleeding before completing active pills, so late cycle, days 10 to 21, increase progesterone to enhance endometrial support. Metaphasic with higher progesterone or triphasic with increasing progesterone. If spotting after withdrawal of bleeding, so early cycle days 1 through 9, increase estrogen or decrease progesterone in the early pills, so triphasic. If mid-cycle spotting or bleeding, increase both estrogen and progesterone mid-cycle. Headaches. If headaches start or worsen after starting OC, need to rule out other causes. Take blood pressure, ask about headache, any focal neurologic symptoms. If related to OC, use and are not serious, discontinue OC, lower estrogen dose, lower progesterone, eliminate pill-free interval, only if headache occurs during the pill-free interval. Decreased libido. Ask about depression. If due to decrease in vaginal lubrication, switch to vaginal ring contraception. Increased estrogen. Hypertension. COCs can cause small increases such as 6 to 8 millimeters per mercury in blood pressure, regardless of estrogen dosage. Low dose COC is acceptable in women younger than 35 with well-controlled and frequently monitored hypertension. Discontinuing the COC usually restores blood pressure to pre-treatment values within 3 to 6 months. VTE or thromboembolism. Estrogens increase hepatic production of factor 7, factor X, and fibrinogen in the coagulation cascade, therefore increasing the risk of thromboembolic events. Progesterones, newer third and fourth generation progesterones, have a greater effect on procoagulant, anticoagulant, and fibrinolytic pathways. Increased resistance to the anticoagulant effect of activated protein C by some progestins. Higher levels of sex hormone binding globulin. For women who are at an increased risk of thromboembolism, consider low-dose oral estrogen contraceptives containing older progesterones or progestin-only contraceptive. See USMEC. Progesterone only oral contraceptives indicated in breastfeeding postpartum phase, older women or women who cannot take estrogen. The failure rate is higher than other progesterone only methods or COCs. Effectiveness is lowered when taken as little as a few hours late. Other conditions in pregnancy: DM1, 2, or gestational diabetes mellitus. Treatment: ADA diet, insulin drug is the drug of choice. Regular insulin or NPH, insulin Lispro, Humalog, insulin aspart, which is Novolog. Insulin requirements will increase beginning around 28 weeks gestation and continue to increase due to placental hormones. Increasing data on safety of insulin glargine in pregnancy. Oral agents, metformin and glyburide, are second line. Reasonable alternative for women who decline to take or are unable to comply with insulin therapy. Hypertension. When systolic blood pressure reaches 160 or diastolic reaches 110. Continue treatment when multiple hypertensives were required before pregnancy or when end organ damage is present. Methyl dopa, labetalol, nifedipine, ER is first line. Hypothyroidism. Levothyroxine is the drug of choice. Attain normal thyrotropin concentrations. Women who receive thyroid replacement prior to pregnancy can expect an increased dosage requirement of 25 to 50% during pregnancy. Depression. Pregnant patients with severe unipolar major depression who were successfully treated with antidepressants prior to pregnancy should generally receive the same drug during pregnancy. For patients who have not been treated with antidepressants in the past, we suggest selective serotonin reuptake inhibitors, SSRIs, as initial treatment rather than other antidepressants. No psychotropic drug with labeling approved by the FDA for use during pregnancy and lactation. First line psychotherapy, but not always an option. SSRIs. Avoid paroxetine, it is a D, during the first trimester related to CV malformations. So that is fluoxetine is a C, citalopram is a C, sertraline is a C. Literature is reassuring. Best data for use during pregnancy. So the best to use during pregnancy would be fluoxetine, citalopram, or sertraline. A risk of postpartum hypertension after 20 weeks gestation with SSRIs. Maybe that's not postpartum, PP hypertension. Risk of neonatal withdrawal or adaptation syndrome 1. DC 2 weeks before term. TCAs, the literature is reassuring. Possible withdrawal symptoms. Atypical antidepressants, limited data. Dyslipidemia. Women who are on statin therapy and anticipate becoming pregnant should stop statins 3 months prior to attempting to conceive. Maternal consumption of fish and marine omega-3 fatty acid supplement is an active area of investigation because of potential favorable effects on pregnancy and offspring outcome. Menopause. Goals: alleviate or reduce symptoms, improve quality of life, minimize adverse drug reactions. Non-pharmacological interventions: avoid vasomotor triggers, hot beverage, spicy food, alcohol, etc. Exercise and water-based lubricants. Pharmacotherapy. Hormone therapy remains the most effective treatment for vasomotor symptoms and vulvovaginal atrophy, especially in women with moderate to severe symptoms, provided there is not CHD, significant CHD risk factors, or history of breast cancer. Oral estrogens. FDA approved for moderate to severe vasomotor symptoms such as vulvovaginal atrophy and prevention of postmenopausal osteoporosis. This is in red. Note: oral estrogen should not be used for osteoporosis prevention in the absence of vasomotor symptoms of menopause or for patients with local symptoms only. The HOPE trial demonstrated low dose provided equivalent efficacy relief as standard doses. Oral progesterones used in women with intact uteruses to reduce endometrial hyperplasia and endometrial cancer with estrogen monotherapy. Must be taken minimum of 12 to 14 days a month. Not necessary status post hysterectomy, so check the surgical history. And this is in red. Length of therapy. The benefit to risk ratio appears to be best if hormone therapy is started close to the time of menopause. Typically can stop 2 to 3 years after starting. Longer durations may be associated with CHD, stroke, VTE, various cancers, etc. Can abruptly stop hormone therapy or can taper. No evidence that tapering of hormone therapy, HRT, reduces the recurrence of hot flashes compared with sudden discontinuation. 1 out of every 4 will need to be reinitiated due to bothersome vasomotor symptoms. Strong consideration for tapering in those on higher doses of estrogen or long duration. Tapering option. Dose taper, progressively decreased dose of estrogen, may require 3 to 6 months in some women. Do not decrease again until symptoms are tolerable and improve. Day taper, decrease the number of days per week HRT is taken. Do not decrease again until symptoms are tolerable and improve. Combination and dose day tapering. Note: progesterone is not tapered. Only the estrogen compound is. Progesterone is stopped at the end of the taper when completely stopping HRT. Vulvovaginal complications during menopause can range from vaginal dryness to atrophy, dyspareunia, which is painful coitus, and lower urinary tract infections, urge incontinence, etc. Local or systemic estrogen therapy for symptom relief. Estrogen can help restore thickness, Elasticity and lubrication. Estrogen can help reduce the risk of recurrent urinary tract infections. In the absence of vasomotor symptoms, local, topical, vaginal estrogen therapy should be used. There is minimal systemic absorption, with exceptions, and does not require the concomitant administration of progesterone.